Allow us to remove the fetus and rest it in its mother's lap while I excise the tumor.
What if we kill her before she kills herself?
That's insane. Hey y'all, welcome back. Mama Dr. Jones, ObGyn, and Mom24. Today I'm going through an episode of The Good Doctor. The most common question that was asked when you guys recommended this episode is, can you do surgery on a fetus? And the answer is yes.
"36 years old, 22 weeks pregnant. Ultrasound at 16 weeks revealed a tumor on the fetus's tailbone.
Mum's got antiphospholipid syndrome. Makes surgery high risk.
Also makes pregnancy high risk. She's had 3 miscarriages.
We need to do an ultrasound and MRI to measure the tumor's growth rate.
Wow, we're just really jumping into it. They're describing a case of someone who is 22 weeks pregnant and the fetus has been diagnosed with a tumor on the tailbone. This could be any number of things, but the most common and most likely thing that this is a sacrococcygeal teratoma, which is just a fancy word to say a germ cell tumor of the sacrum and coccyx. So those can be identified on ultrasound, although they sometimes can be hard to identify and differentiate from other types of tumors. That would be the most common.
Late bus doesn't explain why you're showing up tired after you just had 12 hours off.
We're all tired. The last shift was 36 hours.
I'm not interested in debating the shift schedule with you, but I am curious why you always feel the need to defend him.
We're all on the same team.
Yes, but you're all quarterbacks. And when training camp is over, there's only going to be one starter.
I think there probably are programs that are that malignant. Luckily, where I trained at was definitely not like that.
10.6 centimeters. Half the size of the fetus.
The tumor's grown. Now, it's not cancer, but it is monopolizing the blood supply, which is weakening the fetus's heart. I'm sorry, but there's no chance it would survive long enough to be viable. The safest course is to terminate the pregnancy.
When you get to these points where tumors are that large, they get a very heavy blood supply, and that diverts blood away from the vital organs of the fetus and into the tumor itself. So he's saying it's not cancerous, but it will eventually most likely kill the fetus just because it's monopolizing that blood supply. And then he recommends, in a very nonchalant way, you should just terminate the pregnancy. I am sure that there are people who counsel in that way. I don't think that that would be my choice of counseling, and I think most good maternal fetal medicine specialists I know will lay out, here's the risk, here's the options, and here's the chances that something bad will happen, and here's what you can do. And some people will choose to terminate a pregnancy. Some people in this situation might choose to intervene. That's sometimes an option. And sometimes people will choose to go ahead and just continue the pregnancy and let nature take its course.
If we were interested in the safest course, we wouldn't be on our second opinion. Please, Dr. Melendez, we want whatever will save our baby.
Dr. Wright told us you've done fetal surgery to remove this type of tumor before.
And without the tumor, our baby would be healthy.
Your antiphospholipid syndrome makes a long surgery extremely dangerous. There's a high chance for blood clots, which could have fatal consequences for you.
And they mentioned that she has antiphospholipid syndrome. This is an autoimmune disorder where your body attacks the phospholipids in your blood, and this leads to an increased risk of blood clots. These patients often also have a history, in some situations, of recurrent pregnancy loss. So this can be a cause for recurrent pregnancy loss as well. We generally want someone who has antiphospholipid syndrome to be on a blood thinner during pregnancy to reduce their risk of getting a blood clot in the leg, a venous thromboembolism, or a blood clot in the lung called a pulmonary embolism. The risk in someone who is untreated and has antiphospholipid syndrome is over 10%, which is extremely high. So that's really, really important. It also complicates any surgeries that you need to do on the person while they are pregnant.
We're willing to take that risk.
Saving the fetus doesn't do any good if the mother dies in the process.
I've had 3 miscarriages. If I have to go through that again, I might as well be dead.
No, we'll get through this. We will, and then we'll try again.
We could manage clotting risk preoperatively with an infusion of unfractionated heparin.
I sense that his attending is a little bit frustrated, but he's actually right. That does help to mitigate this risk. It doesn't completely get rid of it, but it does help. And the attending is right as well. There is a risk of clotting that could be a life-threatening risk. And if the mother dies during surgery or because of a blood clot soon after, that doesn't help anyone, including the fetus, who is relying on her to continue growing after the fetal surgery.
Never contradict me in front of a patient again.
I didn't. I agree with your assessment of the risks. I suggested a way we could mitigate them.
I was just reading about a new technique for transesophageal echocardiography monitoring. If there is a cardiac issue, it would give us an early warning.
Let's get her prepped. ASAP.
I like that they've, identified an option for the patient, but they didn't really even talk to her about it. So before they get her prepped, they need to look up the actual risk of the surgery given her antiphospholipid syndrome and talk to her about that and compare that to the success rates of the surgery for the fetus. Because if it's a 1 to 2% chance of success and a 4% chance that she has a fatal embolism because of the surgery, and I just pulled those numbers out of thin air because I don't know the actual numbers, then that may not make sense to them. So I think they need to have that discussion first. But it's good that they're, having the joint discussion and trying to figure out how to proceed.
The umbilical is 19 inches, which will allow us to remove the fetus via cesarean and rest in its mother's lap while I excise the tumor. Now, the hard part will be reinserting the fetus afterwards. We can't overstretch the uterine wall, and we must be certain that every suture is tight enough to handle 4 more months of kicks and thrown elbows.
So the most common question that was asked when you guys recommended this episode is that even a thing? Can you do surgery on a fetus? And the answer is yes. Fetal surgeons generally train in general surgery and then pediatric surgery and then an additional fellowship in fetal surgery, or in obstetrics and gynecology and then maternal fetal medicine and then another fellowship in fetal surgery. So this is a very long training course to become qualified to perform these surgeries. I've never even actually seen one in person. It can be done in an open manner where you make a giant incision on the maternal abdomen and then a hysterotomy, which is kind of like a C-section and is what they're describing in this scenario. Or it can also be done laparoscopically, which tends to be the preferred method in most of the training institutions that I know of right now. However, there are some particular things that they treat that are not amenable to laparoscopic surgery and have to be done in an open manner. The one thing they talk about in this episode is that they have to be careful putting the baby back inside. And in an actual open fetal surgery, they would make a big incision on the mother's abdomen and then a 4 to 5 centimeter incision on the uterus. And they would try to make the presenting part of the fetus at the opening of the uterus whatever they needed to operate on. So rather than remove the whole baby from the uterus, which I don't know if they could even do that and safely put it back in, they would actually operate with the baby still in the uterus open enough that they could access whatever they need to be operating on. As you can tell, this is a very detailed, tiny, difficult surgery, and so there's a lot of risk involved. There's risk that it won't work. There's risks that there will be a complication during the surgery, or that mom will have significant bleeding, or the baby will not tolerate it well. They will both be under general anesthesia, so there won't be any risk of the baby moving around, because the general anesthesia that's being given to the person who's pregnant will also keep the fetus from moving around during the surgery as well. They infuse warm saline into the uterus to keep the fluids there during the surgery, and then once they're done and close everything back up, you may be wondering, how does the water not just leak back out? There is a risk of what we call PPROM, or premature preterm rupture of membranes, after this procedure, but because the incision is made high on the uterus and you go through the amniotic sac high, these will reseal and the baby will be able to continue to regenerate its amniotic fluid. It's really, really, really cool, and that's a very basic overview. There's probably a maternal fetal medicine doctor watching this right now and just cringing at how terrible my explanation was, but that's the best of my understanding for an open procedure, which is what they're talking about in this scenario.
I don't want to do it.
Sorry, but husbands don't have veto power over their wife's medical decisions.
A husband can't stop you from operating on his wife, but a father can stop you from operating on his child.
That's a really complicated ethical discussion there, but I think at the end of the day, this is a fetus that is not viable yet, and the veto power probably would not exist in this scenario. There would be a potential place for an ethics discussion with the hospital, but at the end of the day, what we're talking about here is a fetus that is almost certainly going to die if left not operated on, and the risk of the surgery, the concern being to the person who is pregnant due to her antiphospholipid syndrome. So you'd really have to weigh what he's trying to do. It's clear he's worried about her, which is reasonable. It could be very dangerous. But if the risk is the baby dies either way, he's going to have a hard time convincing an ethics committee that he's trying to prevent them from operating on the child when the risk is actually not to the fetus, then that doesn't make much sense. So I think they're going to have a hard time supporting that. Although I will say, I mean, it's reasonable that he's worried. It's just that conversation needs to be between his wife and him and not trying to like legally stop it or ethically stop it.
Go home and sleep, not play video games or whatever it is keeping you up.
I don't think it's video games.
You can head out too. It's been a long day.
But what about...
Fetal surgery's been put on hold.
What? Why?
Go home.
That was a missed opportunity to have that discussion that I just had with y'all with his residents. I think that is something really important to the learning process of being a doctor, and they should have had that conversation.
Once the fetus is removed from the uterus, one could argue that it becomes a child.
It's ridiculous.
There are numerous legal precedents.
I guarantee the mother's right to choose. It's her body, it's her control.
Until we're certain there is no liability connected to parental consent, neither am I.
The mother has the power to do nothing. And if she doesn't terminate or have the surgery to remove the tumor...
A fetus with a massive tumor will die inside a patient with APS.
And the mother would die too, right?
So we do nothing, and they both die. Or we can do something that's legally and ethically complicated, and maybe they both live.
Yeah, I agree with all of that, except that if the fetus dies, she will also die. I think that's highly unlikely. If the fetus dies, then she will either be induced or have a D&E, and that would be the end of it. It would be extremely rare for a fetal death to lead to a maternal death. Obviously, there is risk of blood clots and infection and things like that, but I don't think that they can definitively say if the fetus dies, she'll die. Other than that, all parts of this conversation, I think, are sensical, although I do think there would be a lot of difficulty really truly getting a legal proceeding to believe that the reason he didn't want them to operate was because of the fetus. It's very clear that the reason he doesn't want them to operate is because of the risk to his wife.
The board has approved the surgery.
Thank you.
Barb, please.
Mark, stop.
I think that's the right decision. I mean, I can't comment on whether the surgery and the APLS and the fetal situation would actually be an indication for this surgery, but given what they're telling us here, I think from an ethical standpoint, she should be the one that gets to make that decision. Now, it is very complicated, and if there was a situation where the other partner was refusing it because of the actual surgery on the fetus, I don't know. I don't know how that would go. It's very interesting, and I think gives us a whole lot to think about.
If you loved me...
No, do not say that.
No, it's true. If you really loved me...
I'm trying to protect you because I love you.
I don't need your protection. I need your support.
We'll start prepping you first thing in the morning. Try and get some sleep.
Thank you.
I have been him standing there and witnessing like a family dispute, and it is very uncomfortable as a healthcare provider to be standing in the room and have to, witness this dispute. And I always try to kind of jump in and say, hey, it sounds like you guys have a lot to talk about, and I'm sorry that this is confusing and stressful, and I can't imagine being in the situation you are. If it's okay, I'm going to just finish up with what I'm telling you, which is we'll prep for surgery in the morning unless you tell me otherwise, and then you guys just chat. I'm going to step out, y'all talk it out, and I'm going to give you some privacy.
Mr. Allen?
I'm trying to convince her to save herself. I don't want to roll the dice with my wife's life.
But she does.
If she dies, it's your fault.
And what if she lives? You're going to have a wife and child who need you, and you keep driving her out of your life. I'm confident. Which should make you feel better.
I think that was a missed opportunity to really sit down and have a discussion with him about, I understand that you are terrified. You're terrified for your wife's life. You're terrified for the baby's life. I mean, that is what is driving him to feel this way. So maybe if there was more, sit down and communicate about the actual risks and benefits of the surgery, which again, I can't comment on because I don't know for sure those numbers, but I think that this probably has a better conclusion than just yelling at him to not drive his wife away.
Patient vitals?
Stable.
Fetus?
Stable.
Okay. Is everybody ready? Knife.
The incision they're making on her abdomen is a transverse incision. In this procedure, if it was an open fetal surgery, we would generally be making a laparotomy or a midline incision because it gives you better visualization, which, as you know, is incredibly important for this kind of surgery.
Retractor.
It's pretty realistic surgery.
Okay. Cutting into the uterus. Having a heart attack. I need you to close the incision.
So it sounds like they are worried she's having a myocardial infarction or heart attack, and they're going to end the surgery right now. I will say I'm not going to show the surgical footage on the screen here, but if you want to go watch this episode, it is season 1, episode 4 of The Good Doctor, and the surgical representation, like what it looks like when they cut into her abdomen and they see the uterus, is very, very accurate.
There was a complication during surgery. A blood clot blocked an artery in your heart. We were able to catch it in time.
And my baby?
The fetus is stable.
So we're right back where we started.
You just had a heart attack.
I don't care.
There is no other option now. If we don't terminate and the fetus dies in utero, the resulting clots will overwhelm your heart and brain.
Which is exactly why we need to try again.
What are you talking about?
You need to remove the tumor.
Because she's not going to say yes to termination, I think is what he's saying. And they're presenting this as she will definitely die if the fetus isn't terminated, which I don't think is the case in actuality. But if we are playing along with that scenario, then I think his reasoning here is she's not going to terminate, so she's going to die if you don't try again.
Thought I could talk her out of it then. Now I know I can't. Either you do it or she dies.
It's not our only option.
You want me to attempt the fetal surgery again?
If it's the only way to save her life.
But a second heart attack one day after the first will kill her.
Maybe not. I have an idea. What if we kill her before she kills herself? We'll stop your heart and put you on a bypass machine for the duration of the surgery.
You can't have a heart attack if your heart's not beating to begin with. It takes the most significant danger off the table.
But aren't the clots a danger to her brain as well?
This doesn't completely eliminate every risk, but it does reduce the biggest one.
That is insane, and I don't know if there's any way that that would actually be something that anybody did. That seems more high risk than just doing the surgery with the APLS. I don't know. That seems outrageous.
She's on bypass.
Cross-clamping the aorta. Flush the heart.
Flushing.
Let's prep her for C-section.
That's insane. So they've essentially now had to do a major surgery on her chest to get to her heart, divert the blood flow through a machine that essentially works as a heart pumping for her. This is sometimes used in like heart transplant surgeries, lung transplant surgeries, things like that. But I cannot imagine that a major chest surgery being put on bypass is less risk than just the APLS and doing the hysterotomy and fetal surgery itself. I can't even verify it because this is so outrageous. Like, the depiction of the surgery itself is relatively accurate, and the discussions about the fetus and fetal surgery are relatively accurate, but that part is out there.
Knife?
Knife.
Bovie?
Bovie.
My heart's beating so fast. A bovie is a electrocautery tool that we use to stop bleeding during surgery with heat.
Are we on bypass? Dr. Kalu, you still with us?
Yeah. Oh, central venous pressure's good. Bypass oxygen tension's 200.
Pretty good job depicting the fetus and the surgery. Again, I'm not going to put a lot of graphic imagery in here, but they do a decent job. In reality, we would not pull the baby completely out of the uterus and do the surgery there. They would make sure that the baby kind of, if the hysterotomy was here, that the teratoma came up through the hysterotomy and they would operate with the baby as much inside the uterus as possible, because you need to maintain homeostasis. The baby needs to be submerged in that water with the warm saline infused around it to keep the baby's skin and body and brain and everything healthy. It would be way too cold to just pull it out and lay it on the table. That would not go well.
Good. Repairing the fetal sacrum, and we'll put this baby back where it belongs.
Baby. That's the first time you didn't call it a fetus.
Just an expression.
I hate people getting all worked up about this. I actually had someone in my last video comment about me calling my own fetal ultrasound an ultrasound of a fetus of my own child. And I don't like this idea that fetus is like a negative connotation. Fetus is a medical term for a human before they are born. I mean, this is not like, it's not a put down to call it a fetus. I use them kind of interchangeably depending on the situation and what we're talking about, and I don't think it's that big of a deal. And the fact of the matter is that is a fetus. It is still alive because it is connected to a placenta and an umbilical cord, and it's going back into the womb. I mean, we can debate about like, okay, it's kind of outside the womb right now. Is it actually a baby? But I don't think that matters, because I think they are just relatively interchangeable, and at some point that delineation becomes very clear, and I hate the focus on this.
I told you.
Yes, you did.
You're gonna need to stay in bed for the next 4 months, but both you and your son's prognosis is excellent.
Hey, we wanted it to be a surprise.
Oops.
Rookie mistake.
I'm glad that they had a good outcome. The reality of fetal surgery is that there's still a chance that things could go south after this. You still have risk of infection. You have risk of the water breaking and not resealing. Risk that the baby could just not do well after the surgery. There's all kinds of complications that come as a possibility after a fetal surgery, especially after an open fetal surgery. So it's not all sunshine and rainbows at this point. It's still a lot of watchful waiting and crossing our fingers and hoping that everything goes fine. If you're new here, I'd love it if you would subscribe, only if you want to, but I'm trying to hit a goal of 700,000 by my 2-year anniversary of uploading OB and GYN content on this channel. Be kind to yourself, to each other, to me. In the comments, be kind, and I will see you next time.